All right, welcome. Let's talk about the heart. I want you to think of it like a really high performance pump. It's got chambers, it's got valves, it's got electrical wiring, the whole shebang. But like any machine, parts can break down. And for the NCLEX, you need to be that master mechanic who can spot the problem, figure out exactly why it's happening, and know which tool to grab to fix it. So let's get our hands dirty and dive in. Here's our game plan for today. We're going to start with the pump itself. What happens when it just starts to fail? Then we'll look at what happens when the heart gets inflamed or infected. After that, broken valves, our key medications, and then the really scary stuff, the crises and complications. And to wrap it all up, we're going to put everything we learned to the test and crack an actual NCLEX-style question together. Okay, first up, heart failure. This is kind of the end of the line for a lot of different heart problems. When you boil it all down, it's about one simple but huge problem. The pump just can't keep up with what the body needs. So here's the bottom line. When that pump gets weak, two major things happen. First, cardiac output. That's just the amount of blood getting pushed out. It tanks. So your organs and tissues aren't getting the oxygen they're screaming for. And second, you get a traffic jam. Blood starts to back up, causing congestion either in the lungs or in the rest of the body. Now, this is absolutely critical for the NCLEX. You have to know the difference between left and right-sided failure. Here's the easiest way to remember it. Left equals lungs. Blood backs up from the left side of the heart straight into the lungs. That's why you get crackles, shortness of breath, and that classic frothy sputum. Right-sided failure? That affects the rest of the body. You'll see that back up in the veins, causing big, bulging neck veins, that's JVD, and swelling in the legs and abdomen. Just lock it in. Left is lungs, right is rest of body. So let's say a patient comes in and they can't breathe. Is it their lungs or is it their heart? How do we know for sure? Well, we check the BNP. This is a hormone the heart releases when it's being stretched and overworked. Think of it like a distress signal. If the BNP is low, under 100, it's not heart failure. But if it's over 400, yeah, that pretty much confirms it. And the higher that number goes, the worse the heart failure is. Okay, so we've seen what happens when the pump gets weak. But what happens when the heart tissue itself is literally under attack? Let's move on and talk about inflammatory conditions. First on the list is pericarditis. This is when the pericardium, that's the protective little sac that the heart sits in, gets all inflamed and angry. The key thing to remember for your exam is that this usually doesn't happen out of nowhere. It often pops up after something else, like a bad respiratory infection or even after a heart attack. And if you remember only one thing about pericarditis, let it be this. This is the dead giveaway. Unlike a heart attack where the pain is crushing and constant, pericarditis pain changes with position. When the patient sits up and leans forward, it physically pulls that inflamed sac away from the heart muscle, and poof, the pain gets better. That is a massive clue for you. Now, if that inflammation digs in deeper, past the sac and into the heart muscle itself, well, that's myocarditis. And because the actual engine of the heart is irritated now, the symptoms get a bit more widespread. You might see a super fast heart rate, new murmurs, and even dangerous dysrhythmias, because that inflammation is messing with the heart's electrical system and its ability to pump right. Okay, so we've talked pump failure, we've talked inflammation. Now let's talk about pure mechanics. Think of your heart's 4 valves as perfect, one-way doors. But what happens when those doors break? So a valve can pretty much fail in 2 ways. First, you have stenosis. This is when the door is rusty and stuck. It's narrowed, it's stiff, and it's really hard to open. The heart has to work like crazy to force blood through that tiny opening. Then you have insufficiency or regurgitation. With this one, the door is leaky. It doesn't shut all the way. So with every single pump, some blood flows backward. It's just incredibly inefficient. Whoa, okay, I know this table looks like a lot. Don't panic. Let's just focus on the patterns, because that's what the NCLEX does. Just look at the aortic valves. With aortic stenosis, because not much blood can get out, the difference between your top and bottom blood pressure numbers gets really small. That's a narrowed pulse pressure. But with aortic insufficiency, blood leaks back in, so that pressure difference gets really big, a widened pulse pressure. See? Little details like that are pure gold for test questions. All right, we figured out the problems. Now, how do we fix them? Pharmacology is a massive piece of the NCLEX puzzle, so let's hit some of the absolute must-know cardiac meds. First up are diuretics, like furosemide. Their main job is to get rid of extra fluid, which reduces the workload on the heart. We call that decreasing preload. But here's the catch, and it's a big one. Most of them, especially loop diuretics, make you lose potassium. So as the nurse, your number one job is to be the potassium police. You're monitoring those labs and teaching your patient to eat foods like bananas and potatoes. This is a huge safety issue. Next up, ACE inhibitors. You'll know them because they all end in pril. These guys make the pump's job easier by relaxing the blood vessels, but you absolutely have to know the side effects. That annoying dry cough, it's common, but angioedema, that's the swelling of the tongue and throat, and that is a 5-alarm fire. It can close off their airway in minutes. You have to be able to spot that immediately. This number, 60. This is your absolute non-negotiable stop sign. We're talking about digoxin here. It's a great drug that helps the heart pump stronger, but it also slows the heart rate way down. So before you ever give a dose of digoxin, you must check the apical pulse for 1 full minute. If that pulse is less than 60, you hold the med and you call the provider. Every single time, no exceptions. You know, the NCLEX is all about one thing, really: patient safety. And that means you have to be able to recognize when things go from bad to catastrophic. You need to know these cardiac emergencies cold. So what happens when left-sided heart failure goes into overdrive? You get this: acute pulmonary edema. The lungs literally start to fill with fluid. Your patient is going to be terrified, gasping for air, heart racing. But the classic hallmark sign, the one that should make alarm bells go off in your head, is a cough that produces pink, frothy sputum. If you see that, you know you have a major emergency on your hands. Here's another killer: cardiac tamponade. This is when fluid builds up in that sac around the heart and starts to squeeze it shut. You need to know Beck's triad: hypotension, JVD, and muffled heart sounds. Think about it. It makes perfect sense. The heart is being strangled, so blood pressure plummets, blood backs up into the neck veins, and you can barely hear the heartbeat because you're listening through a layer of fluid. So, you see Beck's triad. What do? And the order here is everything. Number 1, you get help. You notify the provider immediately. This is not a one-person job. While you're waiting, you can hang some IV fluids to try and buy some time and bump up that blood pressure, and you get everything ready for a pericardiocentesis. That's where they go in with a needle to drain the fluid. Okay, take a deep breath. We've gone through the diseases, the meds, the emergencies. Now it's time to put it all together and think like the NCLEX. Remember, the test isn't just about what you know, it's about how you apply it. All right, here we go. It's a select all that apply, everybody's favorite. So we've got a heart failure patient going home on both furosemide and digoxin. What teaching is absolutely essential? Go ahead and pause here for a second, read through the options, and really commit to your answers. We'll break it down together in a sec. Ready? Let's dissect this thing. A, monitor daily weight? Yes, 100% correct. It's the best way to track fluid. B, decrease potassium? Nope, that's the classic trap. Furosemide wastes potassium, so they need to increase it. C, expect muscle weakness? Absolutely not. Muscle weakness is a warning sign of low potassium or digitoxicity. You report it, you don't expect it. D, hold digoxin if the heart rate's less than 60? Yes, that's our magic number, a critical safety rule. And E, decrease sodium? You bet. Sodium holds on to water, and that's the enemy in heart failure. So the correct answers are A, D, and E. And that, right there, is the secret. Success on the NCLEX isn't about memorizing a million tiny facts. It's about recognizing the patterns. It's knowing that left-sided failure leads to the lungs. It's knowing that furosemide can lead to low potassium. It's connecting that leaning forward helps pericarditis pain. When you start to see those connections, that's when you know you've got this. So my question to you is, now that you can spot these patterns, what's the one clinical sign you'll never, ever ignore again?